Hello, everyone. So now we're going to continue with the second part of antibiotics that modify the wall structure of bacteria. So let's continue with this one. Okay. So the next group of antibiotics are called cephalosporins. And again, just like penicillins, they are part of the beta-lactam antibiotic family because they have a beta-lactam ring. Also, they are bactericidal. That means that they kill the bacteria by destroying the bacterial wall. It says here usually given parentally, depends on the subtype we're talking about. And they have low toxicity where, basically the rash or anaphylactic reaction will be our main concern. So regarding adverse effects, exactly the same as penicillins. Anaphylactic reaction, you need to know how to identify it. Just like penicillins, when you give this medication, you have to be really careful on the first 20 to 30 minutes, and then 1 to 72 hours to see if something else happens. Okay, so let's go over here. How does it work? Same thing. The beta-lactam ring is gonna bind to the penicillin binding protein, and it's gonna break it apart. Resistance, same thing. Bacteria is gonna make an enzyme to fight the cephalosporins. And it's a beta lactamase. And in this case, because we're talking about cephalosporins, the beta lactamases in this group, they're gonna be called cephalosporinases. Let me try it again. Cephalosporinases. Yeah, cephalosporinases. Why? Because the enzymes are attacking cephalosporins. Now, here, instead of having the subtypes of cephalosporins into, narrow spectrum, broad spectrum, stuff like that, cephalosporins are divided in generations, as you can see right here, better over here. So we have first generation, second, third, fourth, and fifth generation. And you don't need to remember exactly the generations, only that there's 5 of them. And we'll do a quick review. But at least you need to learn at least one medication from each family, from each generation. And all of them, they start with Ceph. Ceph with a PH at the end. Or, Ceph with an actual F at the end. So for the first generation, Cephalexin is the most common one. Second generation, Cephalosporin. Third generation, and I guess this is the more famous one, Cefotaxime. Fourth generation, Cefepime. And fifth generation, and this is supposed to be like this, fifth generation, Ceftarilone. So again, there's 5 generations of cephalosporins, and each one, they have a specific group of bacteria or situation where they are used. Now, regarding drug interactions, besides allergies, the other one is bleeding. Cephalosporin can increase bleeding times or bleeding situations for patients taking already blood thinners. Usually, here. It'll be warfarin. regarding this drug. Regarding alcohol, again, never mix alcohol with any type of a drug that the patient is taking for to fight a disease or control a disease. Probenecid, this is a medication that is can increase secretion of antibiotic. So that's the highlight with the probenecid. And if you remember, I didn't mention it, but it's on the slides from the previous chapter. So probenecid is a medication that can increase the excretion time of the antibiotic. So that means it's gonna last less time inside the body, and it's not gonna be able to provide the proper time for the antibiotic to fight the bacteria. Regarding allergies, just like penicillins, rash, and anaphylactic reaction. We mentioned already that there's a cross sensitivity between cephalosporins and penicillins because of the both of them they have the beta lactam ring. Bleeding, especially if the patient is already taking warfarin, we're gonna see bleeding. What type of bleeding? We're gonna see petechiae and purpura. Those are skin bleedings. Petechiae is a bleeding that we call pinpoint bleeding. And they're very tiny bleedings on the skin. You actually have to be close to the patient and see the skin. You cannot see it from a feet away or 2 feet away because it's the bleeding is so tiny and they're like little points on the skin. And purpura, it looks more like a bruise. It's bigger, so you can appreciate it from a distance. So that's the type of bleeding that you can see with cephalosporin, especially if the patient is taking warfarin. If the medication is IV, thrombophlebitis, inflammation of the vein with a blood clot formation. Thrombophlebitis, inflammation of the vein with a blood clot formation. And again, the reason we have thrombophlebitis, and this can happen also to penicillins, is because they're IV drugs. So it's not just because of the medication, it's a presentation of the medication. So here we're gonna do a quick review regarding the different situations where we're gonna use cephalosporins depending on their group. So first generation is used prophylaxis against surgical patients. So that means this is a patient that's gonna have usually abdominal surgery. And like I mentioned before, we have a lot of bacteria inside the intestine. So let's say, I don't know, it can be appendicitis, not ruptured yet. Appendicitis, first stage, second stage. And we don't want a complication, so the surgeon will provide a dose of first generation cephalosporin to eliminate most of that bacteria and prevent an infection. So that's the most common use, prophylaxis before surgery. Second generation, nowadays is very rare to be used. So we'll jump to the third generation. And this is very common for patients that had a bacterial meningitis. So third generation is used a lot for bacterial meningitis. Fourth generation is used a lot to treat pseudomonas in the burn unit. So, now we have two antibiotics that we can use, penicillins and cephalosporins. And the fifth generation, it's kind of new, but is used to treat methicillin-resistant Staphylococcus aureus or MRSA. So those are quick reviews regarding the clinical application of each generation of cephalosporins. And again, the most common question you're going to be seeing is that cross-allergy reaction between them and penicillins, and also how for you to identify a rash or an anaphylactic reaction. If the patient says diarrhea, then you need to think pseudomembranous colitis. We need to suspend the antibiotic. Pseudomembranous colitis is dangerous because it's a super infection where C. diff or Clostridium difficile is the main bacteria, and it can be fatal. The treatment is metronidazole. Again, I'll keep repeating this with a lot of antibiotics. Next one, Carbapenems. So same thing. Carbapenems, they belong to the beta-lactam antibiotic family. Usually, Carbapenems is not first choice regarding infections. Usually, Carbapenems, we hold them until we notice that penicillins are not working or cephalosporins are not working on a specific infection. So we'll let this one to be used in a hospital setting. So far regarding carbapenems, they're not good against MRSA, but we can use it for other infections that are difficult also to treat, like, and I'll put it over here. Osteomyelitis. There you go. It's with a Y. So osteomyelitis. This is infections of the bone that we usually use a penicillin, a cephalosporin. Nothing's going on. We don't see improvements, so we can use a carbapenem. So carbapenems are a stronger beta-lactam antibiotic than the other two. And the antibiotics that we have, imipenem, meropenem, ertapenem, doripenem. So if you notice carbapenems, all of them, they have that penem ending. And that's how you can identify them. Like I was telling you, carbapenems are used only for infections that are already proved to be resistant to other antibiotics. So carbapenems, imipenem, is used only on a hospital setting. It can be used against gram-positive, cocci, gram-negative cocci, and bacilli. Remember, cocci and bacilli is the shape of the bacteria. Carbapenems are only IV. Now, regarding adverse effects, same thing, rash, anaphylactic reactions, anaphylactic reactions, just like we mentioned with penicillins and cephalosporins. So it's the same story here. And if the patient less likely, but the patient says that they're having diarrhea, we need to make sure that it's not pseudomembranous colitis. Again, pseudomembranous colitis is produced by Clostridium difficile or C. diff, and the treatment is metronidazole. So that'll be a really quick review from carbapenems. They're not used that much, and when they're used, it's only in a hospital setting. Oops, sorry. Now, next one is vancomycin, and vancomycin is not a beta-lactam antibiotic. But just like penicillin, cephalosporins, and carbapenems, they inhibit cell wall synthesis. So that means that they don't let the bacteria renew that wall. They inhibit the production of it. Vancomycin is used mainly in hospital settings, mainly IV, and only for severe infections. So same thing as a patient that already went to other antibiotics, there's a resistant, and we can use vancomycin. So it can be used against MRSA. It can be used against Staphylococcus epidermidis. It can be used against C. diff, but metronidazole still more commonly prescribed for it. Again, and the thing is with vancomycin is IV administration and no push. That means you don't push your IV. You put it in an infusion set, and at least per 1 hour. At least per 1 hour. Regarding the adverse effects, red man syndrome. So when you push this medication, when you forget that it has to be infused, when you push it too fast, there's going to be a severe histamine release. And the funny thing, red man syndrome is only from the waist up. So they turn really, 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 really red from the waist up. And well, you need antihistamines to treat it. The other thing regarding vancomycin is ototoxicity, damage to the ear. So here you have to make sure that you evaluate the patient regarding the functions of the ear, and that's hearing and balance. So if you walk into a patient room and you say good morning and they ignore you, and you know that that patient has been in vancomycin for the last 3-4 days, oh, the patient is not being rude to you. Maybe they're not hearing anymore. So you should be careful with those signs of deafness. And same thing, if the patient wants to go to the bathroom and they stand up and they get dizzy and fall down, same thing, it could be ear damage. Another thing that we can add here, kidney damage. So we mentioned BUN and creatinine. So those will be your main adverse effects that you need to prevent on patients. Ototoxicity, kidney damage or nephrotoxicity, and the red man syndrome. So that means that you need blood levels every other day, because this medication is IV. Thrombophlebitis is common on the IV site. Just like any other medication, patient may have allergies where they're gonna develop a rash, or they can have anaphylactic reaction. So here's a little tip. Any medication that ends in mycin and is IV, you need to look for ototoxicity and nephrotoxicity. So I'll put those in red. So again, as a hint, study purposes, for you to answer a trick question on the HESI and the NCLEX, any medication that ends in mycin, and they're giving you the hint, hey, this medication is IV, you need to make sure that the patient doesn't have ototoxic effects or nephrotoxic effects. Okay, now let's go to the next one. This is the Monobactam family. This one also has beta-lactamine. So it belongs to the same family as penicillins Cephalosporins, and Carbapenems. So they belong to the same family and they work the same. The beta-lactam ring attaches to the protein binding, penicillin binding protein, sorry, PBP, and they destroy the wall. So yes, like the previous antibiotics, they bind to the penicillin binding protein, and they're a little bit more specific. Number 3, they are used for gram-negative bacteria, and again, IV. So monobactams are used on a hospital setting, and same thing. We don't use it as a first option. We use it on severe infections where other antibiotics they have failed to help the patient get better. So regarding adverse effects, again, very similar to all the beta-lactam we have been mentioning. Rash, anaphylactic reaction, and as they say diarrhea, less likely because it's IV. But if they say diarrhea, we need to make sure that it's not pseudomembranous colitis. We have to make sure that it's not C. diff. And if it is, the treatment will be with metronidazole as the first option. Okay, and then we have fosfomycin. So again, this is not part of the beta-lactam ring family, but just like vancomycin, it also destroys the cell wall bacteria. And this one has a very specific instruction: UTI, urine tract infections, caused by E. coli or Enterococcus faecalis. Both of them are part of the GI system. And usually when we see it is because there was contamination. We see it, unfortunately, on patients that they get a Foley and there was not a proper cleaning or of the area, and they push the bacteria into the bladder. Regarding adverse effects, again, always look for allergic reactions. If they say diarrhea, we are talking about pseudomembranous colitis caused by C. diff. It may cause headaches, vaginitis, irritation of the vagina, because this medication is going to be excreted through urine. So it might irritate the vulva. It might irritate the vagina. And may cause nausea. Okay, so that's it regarding medications that breaks down the wall of bacteria. Okay, thank you for your attention, and I'll see you on the next chapter.